Most adults over 55 who have had a standard lipid panel will tell you their LDL number. They may have been told it is good, borderline, or high. What fewer of them will know is their apolipoprotein B level. ApoB is a protein that sits on the surface of every atherogenic lipoprotein particle in the blood, every LDL particle, every very low density lipoprotein particle, every intermediate density lipoprotein particle. One ApoB molecule per particle, without exception. This means ApoB is, mathematically, a direct count of the number of atherogenic particles in your bloodstream. And a substantial body of evidence, including Mendelian randomization studies that leverage genetic variation to approximate causal inference, has concluded that particle number, measured by ApoB, is more directly linked to cardiovascular disease causation than the cholesterol concentration carried by those particles, measured by LDL-C. In this video, what the difference between ApoB and LDL-C is at a mechanistic level, what the research says about which marker better predicts cardiovascular events in older adults, the phenomenon called LDL-ApoB discordance that affects a meaningful minority of adults over 55, the limitations of this evidence, and 3 takeaways for how to approach this with your physician. Quick note before we continue, this is educational content based on published research, not medical advice. Talk to your physician before changing your regimen. Now, the study. Understanding the distinction requires a brief trip into lipoprotein biology. LDL, low-density lipoprotein, is not a single molecule. It is a family of particles that vary considerably in size, density, and cholesterol content. The LDL-C number on your lab report is the estimated concentration of cholesterol molecules carried inside those particles, typically calculated using the Friede-Wald equation rather than measured directly. ApoB is different, it is a direct measurement of the number of LDL and related atherogenic particles, because every single such particle carries exactly one ApoB molecule. The cardiovascular risk question is not primarily about how much cholesterol you are carrying, it is about how many particles are crossing the endothelium and entering arterial walls. Particles cause atherogenesis. Cholesterol is cargo. The paper by Snyderman, Ference, and colleagues published in Arteriosclerosis, Thrombosis, and Vascular Biology in 2019 synthesized the evidence for ApoB as both a biomarker and potential therapeutic target in cardiovascular disease. The authors reviewed data from Mendelian randomization studies, a methodology that uses naturally occurring genetic variants that influence lipid levels as quasi-random assignments to high or low exposure groups, approximating the logic of a randomized controlled trial. These analyses consistently found that genetic variants associated with lower ApoB were associated with proportionally lower cardiovascular event rates, even when those same variants did not lower LDL-C proportionally. This asymmetry strongly supports ApoB as the causally relevant metric. The concept of LDL-ApoB discordance is central to why this matters clinically for adults over 55. Discordance occurs when the LDL-C level and the ApoB level point in different directions about risk. The most common pattern in older adults, particularly those who are overweight or have metabolic syndrome, is low or borderline LDL-C with relatively high ApoB. This happens when LDL particles are small and cholesterol depleted, they carry less cholesterol per particle but there are more of them. A standard LDL-C calculation, which depends on both particle number and cholesterol load per particle, will underestimate risk in this scenario. Multiple large cohort studies, including the InterHeart study and the European Prospective Investigation into Cancer and Nutrition, have shown that in populations with discordant LDL-C and ApoB, ApoB is the better predictor of incident cardiovascular events. How prevalent is meaningful discordance? Estimates vary by population. A 2015 analysis by Bocholt and colleagues in the Journal of the American College of Cardiology found that among statin-treated patients, approximately 30% had discordant LDL-C and non-HDL cholesterol compared to ApoB. Among adults over 60, the discordance rate may be higher due to the tendency for LDL particle composition to shift with age, adiposity, and insulin resistance. In absolute numbers, this means a substantial minority of older adults receiving standard lipid panels may be assessed as lower risk than their ApoB level would indicate. Whether that translates to undertreatment in any specific case is a clinical judgment that requires the full clinical context, not a number alone. Several major cardiovascular risk guidelines have begun to incorporate ApoB as an optional or preferred marker. The 2019 European Society of Cardiology guidelines on dyslipidemia state that ApoB is a valid alternative to LDL-C and may be preferred in specific populations including those with metabolic syndrome, diabetes, or hypertriglyceridemia. The American Heart Association and American College of Cardiology 2019 guidelines also endorse ApoB as a secondary target. The Canadian Cardiovascular Society has gone further, with guidance that places ApoB as the primary metric for assessing residual risk after LDL reduction. This is an evolving area and guidance varies by organization and geography. What do the Mendelian randomization data actually show quantitatively? Ference and colleagues published an analysis in the Journal of the American Medical Association in 2017 examining data from over 300,000 individuals. They found that genetic exposure to lower LDL-C and lower ApoB produced proportionally similar cardiovascular risk reductions when expressed in ApoB units, but that when LDL-C and ApoB diverged, ApoB tracking provided the more accurate risk prediction. The relationship was dose-dependent. Each unit reduction in ApoB corresponded to a predictable reduction in cardiovascular events, while the same unit reduction in LDL-C did not produce an equally predictable effect when ApoB was discordantly higher. Now for the critical analysis. Mendelian randomization studies are powerful but not equivalent to randomized controlled trials. They assume that the genetic variants used as instruments do not affect cardiovascular disease through pathways other than the lipoprotein they are designed to proxy, a condition called the exclusion restriction. Violations of this assumption can bias results. Additionally, Mendelian randomization estimates lifetime effects of genetic exposure, while clinical practice involves interventions over decades, not lifetimes. Translating a genetic instrument estimate to a clinical intervention effect size requires caution. A second consideration, LDL-C has decades of randomized clinical trial data from statin studies demonstrating that lowering LDL-C reduces cardiovascular events. These trials did not measure ApoB as a primary endpoint in most cases. Whether achieving a target ApoB rather than a target LDL-C improves outcomes over standard LDL-guided treatment has not been directly tested in a large randomized trial. The observational and genetic evidence is compelling, but the therapeutic evidence is still catching up. This is why most guidelines endorse ApoB as a useful adjunct rather than a replacement for LDL-C in treatment decisions. 3 takeaways from this evidence. First, if you are over 55 and have had a standard lipid panel in the past year, ask your physician whether an ApoB measurement would be informative for your cardiovascular risk assessment. ApoB is a single protein measurement with a well-established laboratory assay. It is inexpensive, widely available, and adds information that LDL-C alone cannot provide. The specific cases where it adds the most are adults with metabolic syndrome, elevated triglycerides, type 2 diabetes, or low HDL, all more common in the over 55 population. Second, understand the specific question ApoB answers. It counts atherogenic particles. It does not tell you whether those particles are already causing damage, how much plaque has accumulated, or what your near-term event risk is. A comprehensive cardiovascular risk assessment includes many variables: blood pressure, blood glucose, family history, smoking history, and in some cases imaging studies such as coronary artery calcium scoring, which directly measures plaque burden. ApoB is one input in that larger picture, not a standalone answer. Third, if you are already on a lipid-lowering medication and your LDL-C is at or near target but you have remaining cardiovascular risk factors, asking whether your ApoB has been measured and whether it is concordant with your LDL-C is a clinically reasonable question. Some individuals on statin therapy achieve LDL-C targets but retain relatively high ApoB levels, indicating residual particle burden. Whether that residual burden warrants additional intervention is a risk-benefit calculation your physician is best positioned to make. Your role in that conversation is to know the right question to ask. To summarize, ApoB measures atherogenic particle number directly, 1 molecule per particle, while LDL-C measures cholesterol concentration inside those particles. Mendelian randomization evidence consistently supports ApoB as more causally linked to cardiovascular events, particularly in populations where LDL-C and ApoB are discordant. the ESC, ACC, and Canadian Cardiovascular Guidelines now endorse ApoB as an important adjunct or primary metric. For adults over 55 with metabolic features, the discordance rate may be higher than in the general population. This is educational content, not medical advice. Always consult your physician before changing your regimen. Studies are preliminary, individual responses vary. If you found this useful, our free guide, How to Read Your Biomarker Panel at 55+, includes a full section on lipid markers. Link is in the description. New evidence reviews publish every Tuesday and Friday.